into our online lunch and learn. Just a few announcements before we get started. Just to let everyone know that our family assisted program grant has closed. We are no longer taking applications at this time. Also, Carolyn documents need should have been submitted by the 15th. So we're trying to make sure all payouts are done and completed by the 30th. So we need all documentation for CareLink grants for the 1920 year. In July the 1st, CareLink will start again for the 2021 year, and applications will be available at that time on our website. Come out Thursday the 25th for our meet and greet in the street. It is going to be so much fun. It's 3 to 5, and we are taking donations. And for every $50 that we raise, we are going to get a chance to dunk Matt, our current ED. So I want a chance to dunk Matt. He deserves it. So please donate. You can go to our Facebook page, and there's a donate button. And please give us a chance to help caregivers and dunk Matt. It is going to be so much fun. Today we have with us Stephen Simmons. He is from Senior Behavioral Health. I always say this wrong, at St. Vincent's. And Stephen I've known him for a few years now. He has about 10 years or more in senior care, but I'm going to let Stephen tell you about himself and his background and kind of educate us on what senior behavioral health is. Because I know when I came into the senior help industry, I heard of senior behavioral health and I was like, I've never heard of that before. I didn't have any idea what it was, what it meant. So Stephen is going to give us a little education today. So it's on you, Stephen.
Thank you, Carolyn. Good afternoon, everyone. My name is Stephen Simmons, and I'm the Community Education Coordinator for Senior Behavioral Health. We're located on the 7th and CHI St. Vincent, the infirmary in Little Rock. Just a little bit about what senior behavioral health is. We are an infant acute geriatric psychiatric unit. So we see patients or treat patients that primarily we treat patients that have a diagnosis of Alzheimer's or dementia. Treatment is not limited to those two diagnoses. We also treat patients who may have a formal diagnosis of major depression, anxiety disorder, bipolar, and schizophrenia. Again, it's not limited to those mental health diagnoses, but those are some of the most common ones that we see. On our unit, the average length of stay is about 10 to 14 days, give or take. Of course, that's usually contingent on how the patient responds to treatment while they are here on our unit. There is a process in order to meet criteria for admission on our unit. And part of my role, in addition to I do the pre-admission screenings. So that essentially is me gathering as much clinical and as much social information about the patient as I possibly can. At that point, I then present to our medical director, who makes the final determination on what a person is appropriate for treatment on our unit. Before we can even move with getting the person on the unit, they would have to be cleared medically through our emergency department. And being cleared medically is simply doing lab work, which is a blood draw, collecting a urine sample, and of course, with our new normal, we're having to do a COVID-19 test. Once all of those things come back, then we can move forward with our admission process. So we talked about some of the diagnoses, some of the things to look for in determining when to reach out for this type of service. You'd want to look for signs and symptoms such as increased confusion, increased agitation, any anger, suicidal thoughts, a person becomes lethargic and less interested in their daily routines and participating in their daily activities, those are all signs that there may be something going on. When you have a person with dementia, a formal diagnosis of dementia, it's sometimes hard for them to communicate exactly what's going on with them. So you want to be proactive when you start to see any signs or any symptoms, and certainly want to reach out for some assistance. The age limit for admission on our unit is 55, 55 and older. And typically referrals that we get come from assisted livings and also nurse facilities. However, we have seen an influx in referral from people that live in the community, either with someone or live independently. I think I may have left off some of the signs and symptoms, but we can cover that if anybody has any questions. What I would like to talk about is some of the things that could exacerbate these diagnoses. And the main causes to exacerbate diagnoses and cause a person to have behaviors would be urinary tract infections. And is one of the main reasons why we have to make for sure that each and every patient through the emergency department, so that if there is some UTI going on, we can actively and aggressively treat that. Most cases, once they're treated, there are some still lingering behaviors that will warrant them to be treated on our unit. There are some rare occasions when a UTI is treated and the behaviors are resolved. So we want to make for sure that we're, diagnosing appropriately and also treating appropriately. Another cause of behaviors could be pain. And again, a person with dementia and other mental health diagnoses, again, there could be a deficit in communicating. So if they are experiencing any type of pain, that could certainly cause them to act out in a way that's not normal to what their baseline is. So once we go through all of that, and I mean, let me back up just a little bit. I mentioned about collecting clinical information. So if a person does live independently, if they are at home, what we do is I'll reach out to their primary care physician, and we will get what's needed is a complete medication list, because we'll have to present that to the doctor, so we have an idea of what a patient is taking as far as their medications. We like to get a full current list of any medical diagnoses. If a person has had any previous mental health treatment, we need to know all of those things and a good decision on whether or not a person is appropriate. And the social information. We'd like to know if there have been any significant changes in a person's life. If they've had if they've suffered a recent loss of a loved one, if they've had a major move, say they moved, mama wasn't doing well in Texas, so we want to move mama from Texas to Arkansas. Maybe a person retiring or losing a job, or any type of family dynamics that could present as a stressor. We'd like to know all of those things, even something, and you may think is simple, but even the loss of a pet could be so significant to where it could trigger some behaviors. So we'd like to get all of that information. And even on the front end of this process, we're gearing up towards formulating a good treatment plan so that each and every patient reaps the maximum benefits of the services that are provided at Senior Behavioral Health. All right, so once we've collected all of that data, all of that information, I present that to the doctor. And the doctor will give me a yes or a hard no on that. And one of the most important things is, because we are an acute unit, the behaviors and the signs and symptoms that I mentioned, those things have to be going on right now. Again, we are an acute inpatient unit, so when a person is having behaviors, we treat what's on right now. And the goal is simply to get a person back to, or as close to, their baseline as we possibly can. each and every person deserves a good quality of life, regardless of a mental health diagnosis. So we want to ensure that we're doing our part and happen for patients that are referred to and accepted on our unit. Um, so we information doctor accepts, and it's a go so long as the patient is agreeable for treatment if the patient does not have a legal status. And what I mean by when I say legal status, if there is a formal power of attorney or a formal guardian, the POA or the guardian gives us consent to treat. If there is no legal status, POA or guardianship, the patient is able to make the decision on whether or not they want to be treated here on the unit. Of course, we can't force anyone for treatment, but the doctor, if he feels appropriate, can certainly recommend for that patient to be treated on the unit. And it gets a little for patients and families because a lot of patients and families that we see when we get referrals, they have never been through this process before. They've never had any type of mental health treatment. And you know, in some families, some cultures, you know, it's just kind of the rug. You know, we overlook our mental health well-being, and right now, I think more than ever, it's most appropriate to, you know, any diagnosis, any signs, any symptoms, get that addressed. Um, so, like I said, it's a stressful time. It's a stressful situation and a decision to make. So we take our time with it. You know, we are not a pushy group of people, and we're willing to have these conversations as we need to answer as many questions as we. And I certainly encourage each and every family, every patient that I talk to be diligent in asking those questions. You want to be able to make the most informed decision as you possibly can about treatment. So we'll have as many conversations as we need to before we move forward. We'd like for everyone to be on the same accord because we really lean heavily on our families because they're just as much involved in this treatment process as the actual patient is. Once everyone is all in agreement about admitting a patient onto the unit, we go through the admission process again. That's after they're cleared through our emergency department. There would then be a direct admission onto our. So the average length of stay is about 10 to 14 days. Like I said, we have 16 beds total. So that means there are 8 rooms on our unit, and the rooms are all semi-private. Just to kind of briefly going over the schedule for the day, we wake the patients up at 6:30. We encourage socialization. So once the patient's up and out of their rooms, the doors are closed and we lock those doors. And that's just a safety measure. And because we do have patients that, sweet little patients with dementia, sometimes like to wander and they're sometimes pleasantly confused. So we want to just make for sure they have eyes on our patients at all times. We have a large group room that's on the unit, and we use that room to facilitate our meal service, of course, breakfast, lunch, and dinner. And we also do our group activities in the day room as well. Once they're on the unit, medication management is one of the methods of treatment that we use. I mentioned getting a complete medication list from the patient's primary care physician. That's important because the psychiatrist will, in fact, do some adjustments to medications, either increasing or possibly adding new medications. Um, you know, like I said before, we like to be transparent and we want the families to be involved because we certainly need them to be agreeable board with the doctor's decision as far as the medication management is concerned. In addition to the medication management, we also offer therapeutic group sessions, and those are done every day. The group sessions are facilitated by our licensed social worker, also our recreational therapist. So the whole point of these therapeutic sessions is to engage the patients. We want to offer, you know, that cognitive stimulation. We want to simulate situations in the community because typically that's the goal. The goal is for the patient to return to or discharge back to the place in which they admitted. So we want to stimulate different, types of situations. In these groups, we are also doing psychoeducation. So what's encompassed in the psychoeducation are coping skills. How does one cope when faced with situations that may present to create some anxiety, to cause them to get angry, to cause them to want to isolate? These psychoeducation groups are instilling or equipping our patients with mechanisms so that they aren't overcome by those feelings of, anger, fear, anxiety, all of which enables them to live quality of life again successfully in their respective communities. And the recreational therapists, those are fully engaged, more physical activities, and they range from, we do music therapy, we've danced on our unit, we've done all kinds of artwork, more physical activities such as bowling, beanbag tosses, things like that. And these are all good. And again, having our patients to be able to socialize and function in general type situations. Let's see. Some of the other services that are offered on our unit, in addition to the medication management and also the therapeutic group sessions, our patients can actually have physical therapy, occupational therapy, and speech therapy. And those three disciplines are offered to all of our patients. They will be assessed one time, and if continued therapies are needed, that service is certainly available for while they are here on our unit. Let's see. We are a 24-hour admit referral unit, and as far as insurance is concerned, we take just all the insurances. We take private insurances. We accept Arkansas Medicaid. We also take traditional Medicare and also managed care insurances. Let's see. All right. And as far as contacting us, we are, you can go to the CHI St. Vincent website. That is CHI St. Oh, it's there on the screen. And a lot of what I covered is on that website. It's not as detailed. There's also during business hours telephone number that's available, and also after hours telephone number that's available as well.
Hey, Steve. So, in wrapping this up, there was a lot of information, but I do have a question, and actually, it's probably like a question with three questions from one person, and I think it's really important. I think so. Is Ms. Burton? I don't know how to pronounce her first name. So she would like to know more about symptoms. So I think when we talk about symptoms, is knowing like some of those acute symptoms, because you give some of the acute symptoms that you can look for, like the agitation, the fighting, and where does she start? Like, since you have to, do you call 911? Do you call your doctor? Like, where do you start and whom do you consult? So she just really needs to know, like, what the symptoms, the more acute symptoms are, and where does she start to get these services?
Yeah, and thank you, Ms. Burton, for the question. So, and and like I said, a person with a formal diagnosis of dementia, there are, and that's what dementia is. It's a group of symptoms that impact a person's memory. So there could be, just kind of run-of-the-mill baseline symptoms, confusion, repetitive speech, some memory loss, things like that. And as long as, our loved one is able to function instead of a quality of life, safely function, in their respective community or living space, those things can be managed at home. It's when these symptoms become worse, when they become more frequent, when they go from every other day or every 2 or 3 days to we're starting to see them more frequently every day. Mama is repeating things. Mama can't remember, something that I something that you may have told her, just a couple minutes ago. If she all of a sudden stops eating, drinking, wanting to take her medication, if she's unable to recognize you, whereas she had been able to recognize you a couple of days before, or if our loved one becomes combative and hallucinating, those are two really big ones in the acute side of it. If they've become combative, if they start hallucinating or audio hallucinations, when those things happen, when you notice those things, I think if it's not a situation where they present to be an imminent danger to themselves or someone else, you can certainly consult your primary care physician. If it is a situation and the behaviors, signs, and symptoms are exacerbated to the point where you feel like, well, mama's wandering has gone from just throughout the day to she's wandering at night, and I'm afraid she's going to get out and wander into the street. Those situations like that, I think, will warrant calling 911.
Okay. So if you feel if something happens, kind of clear this up. If there's a behavior, and I really hate using the word behavior, but that probably fits most. So if there's an incident happened that this is abnormal, out of like this has never happened before, she's or the your loved one is harm it to themselves or even the wondering, like maybe they wander around the house, and then today it goes beyond like wondering and like wanting to get out to like wanting to be combative, and when they're trying to get out, like those kind of things, Steve. Like
Yeah.
I don't.
So
So you consult your primary care physician first.
yes. So again, you don't want to you want to make the most informed decision, and you want to make the
Okay.
best decision because we're making these decisions for someone that we love, and that's a stressful thing to bear. So while you don't want to pull the trigger too soon, you don't want to ignore these things. So
Okay.
if these behaviors, if they present where oh well, um, she didn't do that 2 days ago, but she did it today, and it's kind of a first. Consult your primary care physician, and also keep a watch eye on those behaviors and worsening behaviors. And as those behaviors, if they become worse, if it's a situation where the patient or the loved one is in any type of imminent danger to themselves or a threat to someone else, then you certainly want to reach out and get help immediately.
Okay. So I wanted to kind of touch on also visitation. So if my loved one is admitted onto a facility like a behavioral health, like what does visitation usually look like, and how does it look now because of COVID-19?
Great question. Again, like I said, we want the patient's families to be just a part of this transition as the patient actually is. So, right now, because of COVID-19, we have restricted visitations. Once that loosens up, we will go to one visitor per day. Excuse me. And I'm not certain on what time that will be. But again, my contact information is available. So you can certainly reach out to me for that. So it's going to be in baby steps. So again, we've restricted visitation as of right now. However, the phones ring 24/7. So you can certainly call the unit, ask to speak to the nurse, and with we generate a code, of course, for HIPAA regulation. So you'll have to present the code when you call to the unit, and then at that point, the nurse can release any medical information, answer any questions that a family may have. And like I said, once we loosen up the restrictions a little bit, one visitor per day. and we'll have to secure a time on what visitation is. Now, when a person comes to visit, we do not allow any personal items on the unit. No food is allowed. So a person's phone, cell phone, purse, um, coats, anything like that will be secured in a locker space, and then at that time, the family member can go onto the unit to visit the patient. And then once things start to loosen up even more, typically when we first open, and we hope to get back to the same visiting hours, is from 11 to 1 and 5 to 7. And when those visiting hours open up, we allow 2 visitors at a time.
Okay. So one more question. You were talking about coping skills for the patient, that you provide a lot of skills, and sometimes we know that when it comes to Alzheimer's and dementia patients, like teaching them a coping skill is nearly impossible. I'll say it like that. So do you provide coping skills to families, like resources to families as well as they discharge home, maybe some tips on coping skills to help handle their loved ones or manage those behaviors?
Yeah, and that's a super awesome question, and thank you for asking that. So, in addition to the group therapies on our unit, we also offer individual therapies, and that is extended to both patient and the patient's family. Again, most of our patients, this is the first time that they've ever been faced with a situation like this, and it takes a toll emotionally, not just on the patient, but on the family members as well. And we need the family members to fire on all cylinders. So if there are some deficits, if they are struggling and coping, emotionally with the idea of their loved one being on a secure unit or a psychiatric unit, I mean, just the word psychiatric unit, or those words, those are scary words. And so we certainly offer those therapies to both the patient and the patient's family. And our social worker, she's equipped contacts in the community, and also literature here in the office that's available to the patient's family.
Okay. So I think we don't have, I think that was our last question. And I want to thank you again, Stephen, for educating us on senior behavioral health, because I know as people get into caring for their loved ones, and when people suggest a behavioral health or a psychiatric unit, the first thing they say is like, nothing's wrong with my parents or my loved ones' mental health. And just being informed that just like our physical health, we have to also take care of our mental health. So it is a thing. Our mental health is something that we do have to take care of, and sometimes it gets off, and there are resources to help get you back to that baseline. So I want to thank you very much for all your information. Again, everyone, you can reach Stephen at we provided the website. You can call him. You can look on our Facebook page, our YouTube page. We will have that information as well. And as we close, just to remember that on Thursday the 25th from 3 to 5, we are having our meet and greet in the street, and we are raising funds to go back into giving our caregivers some resources like for respite care, and making sure that we provide the services that we have always provided to the caregivers, and getting a chance. I'm excited to dunk Nat. So please help me dunk Nat. And if it's anybody out there that want to give me some tips on making sure that I can hit that target, please hit me up and let me know. Next week, we will have our own Erica Cross. She is going to be bringing some great information on Alzheimer's and dementia, and reducing the risk, and some other information. So please come back next Thursday, same time, same place. And thank you again, Steve. Talk to you guys later.
Hey, can I add one more thing?
Just one. Just one.
Okay, one more thing. So, because we are a secure unit, there is a misconception, and I just want to clear it up. We've done our best to take the institutional feeling out of our unit. So our patients are allowed to wear their regular clothes. They need 3 changes of clothing, and we ask that patients stay away from anything that presents as a ligature risk. So no shoestrings, no belts, no drawstrings. And we don't strap patients down to beds, and we don't do any type of shock treatment on our unit. And I know that, as silly as that may sound, but those are serious, legitimate questions that I've been asked. So I just clear that up. We're not strapping your loved ones down. They don't have to wear a specific type of uniform. They can certainly wear their regular clothes here on the unit.
Thanks for clearing that up, Steve. Thank
You're
you
welcome.
so much. All right, bye.
Thank you for having me.
Everyone have a great day. See you. You can say